give it just a little bit longer. All right. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on implementation science. My name is Alson Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, May 20th. I am joined today by NHF's own Lena Volland. Thank you for taking the time to join us today. I'll go ahead and turn it over to you to get us started.
Thank you so much for that very warm welcome. And hello and welcome to everyone out there joining us today for our Wednesday webinar. Here, I'm very glad that you're making yourselves available on a Wednesday afternoon, morning, or wherever you are in the time zone wherever you are. So again, my name is Lena Volland, and I'm the Director of Education here at the National Hemophilia Foundation. However, just to lay the lens out here a little bit, I'm also a physical therapist who used to work at a hemophilia treatment center, and I'm a translational health scientist in the making. And today I have the honor to talk about a topic that's very dear to my heart, which is implementation science, which is a component of translational health sciences and has become quite a buzzword in the community out there in our research field. So today we're going to highlight implementation science and talk about the connection of implementation science to our bleeding disorders community. So just to briefly highlight again, the mission from NHF is here, and we are really focusing on helping people to thrive, and implementation science will be very important for that. But first and foremost, what in the world is implementation science? What does this term mean? Where's this coming from? How are we viewing this? So I want to ask you a couple of questions out there, and I'm going to put a little bit of food for thought out there. So to lay the land, I want everybody to think a little bit about a New Year's resolution. What was your last New Year's resolution that you actually had? So a lot of people are laying these out at the beginning of the year with the emphasis of really implementing something new in their life. Very often, that might be, for example, losing some weight, going more to the gym, spending more time with loved ones, right? So then I want to know, did that actually work? Did your New Year's resolution really work? Were you able to implement it to the fullest capacity, or did you fall off the bandwagon along the way? So for example, maybe your New Year's resolution was truly to go more to the gym, to work out more. So at the beginning of the year, you got your new gym membership. You might have gone a couple of times in the first couple of weeks. The next month, you just went once or twice. And then by the third month, you dwizzled off again. Somewhat familiar? Or maybe you were able to stick with the new plan. So very often, though, plans don't really work out, and they don't work out the way that we set them forth. And it's not really the fault of the intervention itself. So we know that going to the gym is definitely beneficial for us, but we got to think about, why did it actually not work? What were all the different issues that prevented us from really following through with our plan? And that is exactly where implementation science steps in, and where implementation science becomes so very much important. So when we are connecting this to our healthcare world, there was a big call out, and this was based on a study a couple of years ago. And what they found, and this was truly astonishing to many people, is that it takes on average 17 years to move an effective intervention into practice, meaning that in research, we have found an intervention that is efficacious and effective. It works very well in our controlled setting, and we have found it to be very beneficial to our patient population. But then it takes about 17 years from that intervention that is sitting on somebody's desk, that has been published and has been brought out there, to be actually implemented into the clinical setting, so that the real target population so the patients themselves can benefit from that intervention. Now, another really scary thought is that only 14% of the interventions actually reach the target population in the real world, meaning that in research, we have found solutions for a lot of problems that are out there. But then when we are putting them into the real world, it might not work, or they are never really being fully implemented. So we have a lot of wonderful ideas, wonderful solutions to many problems out there, but the people who would mostly benefit from it are never really being able to benefit from it because they don't receive them. And that is exactly why we need implementation science, and why implementation science is really there to close this gap. So for once, it is there to shorten that time frame, because in all reality, let's face it, 17 years for a great intervention and a great solution to be just sitting on somebody's desk until a patient can actually benefit from them, that is not acceptable. So we got to shrink the time frame. The other part is 14% of interventions are only really reaching people. That is not enough. So we really want all of these great innovations to be successfully implemented so that we can improve the lives of the people that we serve. So this is really why implementation science is so important. And it has really grown into its own scientific field over the last 10 to 15 years. So it's a rather new science. But it's really geared into closing that gap, into tightening the time and bringing more of the great innovations from research into our day-to-day clinical practice. So I want to give you a little bit of an example here of how this actually plays out in the bleeding disorders world. And we can really pull from many different examples. But I love pain management, so we're going to bring in a little bit of pain management here. So in research, there's an established connection between chronic pain and anxiety and depression. So anxiety and depression are closely related to chronic pain and vice versa. So in 2020, the MASEC recommendations for chronic pain management were published. And one of the recommendations in particular suggests that those people with bleeding disorders who have chronic pain should be regularly screened for anxiety and depression. Sounds very normal, very plausible and easy, right? So that screening should normally occur at the HTCs. And then the thought process is that patients that are in need of additional mental health services, along with all of their pain management, they would be identified, and then they would easily receive the mental health services. And then at the end of the day, the outcome would be a positive impact on their health outcomes. Well, that is in theory how it should work, but unfortunately, that's not how it works in the real life. So this is the moment where we're taking something that has been identified in research into the real world setting. And now we have a multitude of confounding factors that are limiting our ability to get to the ultimate outcome that we are so hopeful to get. So, but here's the problem. Why is this happening? So if something has demonstrated efficacy and effectiveness in the laboratory setting or in a little bit of a larger clinical setting, then why do we still have implementation challenges? Why is this not happening? Normally, we would think if something has been found to be working, then why is it so hard to make it work in the clinical setting or in the real world? Well, this is what we call a complex, wicked problem. So the problem here is that while the intervention worked in our very reduced, controlled environment, that in the moment we're moving it into the real world setting, we have a lot of additional factors that will now influence the outcome of our intervention. And I really love this quote here, which, while it is a little bit older, holds very much the truth here. One of the most intractable problems is that of defining problems, of knowing what distinguishes an observed condition from a desired condition, and of locating problems, finding where in the complex causal networks the trouble really lies. Now, in turn, and equally intractable is the problem of identifying the actions that might effectively narrow the gap between what is and what ought to be. So I really love this quote. And again, while it is older, it very much holds true when we're looking at complex, wicked problems. Very often, there are many, many different factors that are influencing the outcome of our implementation. And it is difficult to identify where the true issue really lies. And then once we have identified our real issue that is limiting us to implement that great intervention, we also will have a difficult time to understand often what are the actions that we really truly need to take so that we can narrow that gap, so that we can truly successfully implement our innovation. So what are those factors, those confounding factors that are influencing our implementation, or what really is a wicked problem? What constitutes a wicked problem? Now, going back to our example of the pain management component for people with bleeding disorders, where we identified we need to screen people, need to get them the services, and then that will improve their overall experience of pain. That is influenced by individual, contextual, and external factors. So individual factors are those that are influenced by the person themselves. In the pain management example, that might be the healthcare provider's understanding of the different tools to be utilized to screen for pain, or maybe not being able to access these. It might also be the patient's perception of being screened for anxiety and depression when they're thinking about pain management. Now, contextually, that's really the organization and the system where the HTC or the healthcare provider is located in. So while they might have a good understanding and a good attitude about the screening for anxiety and depression, there might be some limiting factors from the organization itself. How would, for example, a screening tool be implemented into the clinical flow? Are there any limitations to accessing this? Can the results of that screening, for example, be actually read or be moved forward to the appropriate healthcare provider? Are there any other policies within that organization that would limit any sort of implementation? So it's really the structure itself of the clinic. And then we have the external factors. So externally, we are really looking into laws and policies on a state or on a federal level that might influence or impact our ability to implement the intervention. For example, going back to our pain intervention here, or our screening for anxiety and depression, one of the elements would, for example, be access. How is insurance really driving a person's ability to be seen at a hemophilia treatment center where they would have access to the appropriate healthcare providers? Or let's say they would be identified as needing some additional mental health services. How can they access these? Is their insurance going to cover that? So there's all of these other confounding factors that truly prevent us sometimes from successfully implementing something that we know from research is actually working. And again, this is where implementation science steps in. So when we're looking at these rather wicked, big, complex problems that are driven by multiple confounding factors, we really have to employ a systemic thinking process to really solve these. And there's this picture with the elephant that I know many of you are familiar with, where you have a lot of blind people in a room. They are all touching an elephant and they're all identifying different issues. So what we really have to think is put on a big picture view. So we really need to start making sense of the world rather than describing little bits and pieces. And we need to consider the whole system with all of its complexity, with all of the confounding factors. And the beauty of really thinking in a system is that it allows us for some feedback loops. It allows us to really identify and reiterate our processes, analyze as we move along, really making sure that we are solving our rather wicked problem by identifying all of the issues in the entire system and mitigating these. Now, when we're thinking about a system is really established through its individual elements. So the people within it, the structures within it, and the governance of it as well. It also is established with the links and the interrelationships between these. How are these different elements impacting each other? And then the boundaries. Where are the different boundaries of that system or the systems within? And then, of course, the perspectives. Each of these elements has human beings associated with them. There are the patients, there are other stakeholders, our healthcare providers. Each of them have a different perspective. Each of them have different values and perceptions of the entire situation. And all of those perspectives have to be put into consideration as well when we're talking about a wicked problem and how to solve this. So it is not easy, it is complex, and that is exactly why we need implementation science. So as we move along through this and we talk a little bit more of implementation science and how we research these rather wicked problems, I want to lay down a little bit of the terminology here so that we're all on the same page. So when we're talking about implementation science, this truly is the study of the methods to enable the adoption of an evidence-based intervention into healthcare policy or practice. So we are really looking at the methods here, not the intervention itself. Now, when we're thinking about implementation practice, this is really our local knowledge. So this is the use of strategies to adopt an evidence-based healthcare intervention into clinical practice within or across specific systems. So this is very much our localized knowledge that we have within the clinics. So these are all the different strategies that we really need to utilize to implement an intervention, a program, a treatment, or their such. And then we have our implementation research, and this is where we're generating generalizable knowledge. So not just knowledge on a local level within one clinic, but knowledge that we can spread across multiple institutions, across an entire country, or even globally. So this is really then our evaluation of the use of strategies to adopt evidence-based health interventions into clinical settings and improve patient outcomes. So it's really the evaluation of the totality. And then we have our implementation strategies, as I mentioned before. So these are specific tactics, and we'll dive into these a little bit later, but these are specific tactics to support the adoption of an evidence-based intervention. So these are the steps that we do. Like, what do we actually do to adopt this intervention or to integrate it into our clinical practice? And then we have our implementation outcomes. So that's really then the evaluation of the level of success. How good of a job did we do? Were we successful in implementing these, or did we fail along the lines? And this is really where our feedback loops consistently come into play as well to really make changes along the way. So just wanted to lay a little bit of the terminology down here as we're moving through this. So I wanted to talk a little bit about the traditional translational pipeline. This is really driven by NIH, and many of you will be very familiar with this. But we're really differentiating here between efficacy, effectiveness, and implementation. So when we're thinking about research, about a treatment, a program, something we really start out with our efficacy, and that's really, could the innovation potentially work? So we might have a great idea, and this is where we might need to be in our very controlled laboratory where we're looking at a potential solution to a problem, like a new drug, a new medication. Could this potentially work? Would it actually solve our issue? And then we're looking into the effectiveness. So does the innovation actually work when we're putting it into more of a clinical setting? So here we're still very much reducing and controlling the environment, but not to the degree of a laboratory setting. So it's a little bit closer to real world, but not completely. And then it really brings us to our implementation. So this is where we are making the innovation work. So let's say we have discovered a new treatment for our bleeding disorders community. We found it that it is effective and efficacious, and now we have to implement it into our clinical setting. And as we're going through these on the bottom, there's really a lot of pre-intervention work, moving into the efficacy studies, effectiveness studies, and implementation. That's kind of the traditional pipeline that we are moving in. Or to show this a little bit differently, and I really enjoyed this graphic Elaine form from 2019, where we really need to identify when we're setting up our research and we're designing our research and we really want to develop something new for our community, where are we and what really needs to happen with this? So we might have an idea. Then we need to see, well, is there any sort of evidence yet that says that this is actually efficacious? Does this actually work? If not, then that really needs to be my arm of where I go with my research. So I can't really implement something that doesn't have shown any efficacy. So this is where I need to go. But if I see in the research, if I go into my literature and I can see that it has been proven to be efficacious, that's where I can then really ask myself the question, well, is it actually effective? Has it been shown to be an effective treatment? If no, then that needs to be my research arm here. If it only has been partially shown, then I can kind of think about a hybrid effectiveness implementation trial. But if it has been shown effective, that's really when I can have my clear effect of implementation. So there I can really move on of implementing my new treatment approach into the clinical setting. So that's really kind of the pipeline and how I would set up the pipeline with my research. So I wanted, sorry, to highlight this a little bit more of what really the difference between effectiveness and implementation is, because very often these become a little bit mixed when people talk about them. So I really wanted to hone in on what the key difference here is between looking into effectiveness research and implementation research. So when we're thinking about effectiveness, this is on the left side, the image here, we are still very much focused on the evidence-based innovation. So whatever my program was, my treatment that I developed, I want to know whether or not this treatment actually works. Now, within effectiveness, I'm still going to measure a little bit and look slightly into the system to support the adoption and delivery with fidelity. So this is still a component of it, but it is not the main focus. It is not in the foreground. So when I'm looking into effectiveness studies, I'm really focusing on whether or not my idea, my program, my treatment actually works. Now, when I'm moving into implementation, this goes into the background. So I have proven that my innovation is evidence-based and it works. It works in my rather controlled setting. So now I need to focus much more on the system to support the adoption and delivery with fidelity. So this is really where the focus now is. We're not so much concerned on the intervention itself. We are concerned about how to make it work within the clinical setting. So what that means is we are changing what we are measuring and we're changing on what we are investigating when we're setting up these studies. So effectiveness really focuses on the evaluation of the actual health outcomes of the innovation, whereas implementation focuses on the evaluation of the adoption of the innovation. So some examples of this might be reach, the fidelity in itself, maybe some cost, some speed of delivery, elements as such. So it's really focused on all of these confounding factors that could essentially prevent us from making this evidence-based innovation work in the real world setting. So you might say, well, that sounds a lot like QI. That sounds like a quality improvement project that a lot of clinics and a lot of healthcare providers are currently establishing in their clinics. Well, there's a slight little difference, and I wanted to note that here because I'm sure that many of you might actually have these questions. So QI is really a specific problem in a specific healthcare system. So this might be very unique to the clinic that you are actually working at. So this might not be generalizable to other clinics or the broader public. So what that also means that it requires a specific intervention that is aligned with the identified problem and the system. So it needs a very specific solution for the clinic itself. And very often you might hear in healthcare and in other industries too, approaches that are often used are Lean or Six Sigma. That's really for quality improvement. Now, implementation science really generates generalizable knowledge that can be widely applied. And that truly begins actually with the innovation. It begins with what I have identified as my evidence-based innovation, my program or my treatment. And that program is currently in my clinical setting not utilized or underutilized. And that is what I want to improve. So it is a little bit slightly different, though they are tightly connected as well. Now, when we're finally reaching that stage of implementation, this is kind of where we really then want to move also from our local knowledge into the generalizable knowledge, which is a two-way street. And I wanted to introduce the EPIS model here. So the EPIS model is really laying out the land of how we are moving into implementation, which moves from exploration, preparation to the actual implementation process and then sustainment. So it is not just that we want to identify what our program is, what it should look like, and prepare for actually implementing it into a clinical setting, but we also want to make sure that it stays and that it is sustained and that we might even be able to scale it up. So that, again, brings in all of our feedback loops and maybe some changes that we need to make along the line, but it allows us to really bring our treatment or our program into the clinical setting. So this is the APIS model by Ahrens. Now, in order to conceptualize this a little bit more for the clinical setting, and I know this is all rather complex here and a little bit theoretical, so bear with me. But in order to conceptualize my innovation and how I want to bring this about in the clinical setting, we are often looking towards theories, models, and frameworks. Now, the problem here is that these words or these terms are often used interchangeably. But I wanted to make sure that we have a clear distinction between these, because these build the foundation and the grounds for our conceptual framework of how I'm actually bringing my treatment into the clinical setting. So theories really describe meaningful relationships between constructs. So it kind of explains to us in a rather philosophical way of why things are the way they are. Why is my patient behaving in this particular way? What are all the different confounding factors that are leading to that behavior? Now, then I have models. So models are operationalization or a simplification of a theory. So they are built on a previous rather philosophical theory, and they're putting it into a nice model so we can see what is actually happening. The health belief model would be a good example for this. And then we have frameworks. And frameworks are really an organization of constructs without causal relationships. So these are our roadmaps. This is really where they explain to us how we can implement something or what our different processes are. So again, theories, rather philosophical, overarching explanations, models, simplification of a theory, frameworks is our roadmap. So when we're looking into implementation science, we really have, again, that theoretical approach that then leads us to different models and frameworks. So this is a different way of showing this, which was done by Nielsen in 2015, and really explains how we're using these different conceptual elements into creating something that works for us. So we're starting out again with these theoretical approaches, but then we might actually have models and frameworks that are describing or guiding the process of translating research into practice. So these are our process models. This is really a step-by-step instruction manual. The knowledge to action framework would be a good example of this that really outlines the step-by-step process. Now, then we will also have understanding and explaining of what influences the implementation outcomes. So these are different models and frameworks that really help us get an overarching understanding. So we might have our determinant frameworks. CIFAR is a good example for this. We might have classical theories, or we might have implementation theories. For example, a good example would be here, the readiness of an organization, organizational readiness. And then we have our evaluation implementation. So these are our evaluation frameworks. So once we have actually implemented a program or a treatment, how are we evaluating this? How are we making sure that it actually truly works? So there are different frameworks, so different roadmaps of doing this. And that's how we're using it a little bit in our implementation science world. So now let's think a little bit about methods. So you've heard about, well, we have identified a rather wicked problem. We have identified all the contextual frameworks. Well, what are some of the methods that we are using in implementation science? And it really depends on what we're looking at. But in general, we are looking towards proximal implementation outcomes, such as the adoption, cost, feasibility, fidelity. We're also looking at potential intermediate service delivery outcomes. So it's really just the service in itself. the equity, timeliness, speed of delivery, and so forth, and then really distal health outcomes. So what is the ultimate outcome for the patient? And there's many different ways, really depending on what we are focusing on. In the center, we always have our delivery system, so our healthcare system. But now we want to know different elements of it. Stakeholder and policy might be analyzed. There's an element of dissemination research. Social marketing can be researched, surveillance and data systems, our big databases. Impact evaluation, we might look into economic evaluations, the quality, the operations themselves. We can do system analysis and improvements, and then organizational assessments. So all of this is really centered around the health service system and about the operationalization of it. So we're really looking into all of the nitty-bitty details there. There's many different methods. So you've heard me talk earlier about implementation strategies. So we have talked about different innovations, but how are we actually implementing this? So I wanted to highlight two studies here by Powell and by Waltz from 2015 that were really laying the ground. So this is the EPIC project that really laid out what are the different elements that we can actually do and what are the best implementation strategies out there. So they had a very sophisticated Delphi method to really come to a consensus of what the big buckets are. So these are all listed here, and each of these have individual subgroups with different ideas for implementation strategies. So again, the strategies are really the vehicles that help us implement a treatment or a program in the clinical setting. And we need to pick the right strategy based on our analysis of what the actual problems of the wicked situation are. So it might be that we need to look towards engaging consumers, so our patients, their family members, their caregivers. We might need to just engage them a little bit more, teach them, provide them with education, bring them to the table. We might also need to develop stakeholder interrelationships. And this goes often beyond our consumers. Who are the other stakeholders that are important for the implementation process? And bringing them to the table, hearing them out, hearing their struggles, and then mitigating from there. We might also use evaluative or iterative strategies, so really evaluating the processes. We might utilize financial strategies. Sometimes we need to go into the finances as well, make some alterations there. We might actually need to change the infrastructure. And then especially when we're looking towards those contextual barriers that people might face, maybe we do need to change the infrastructure. For example, when we're looking towards the pain management in people with bleeding disorders, maybe the patient would benefit greatly from physical therapy, but the HTC itself doesn't have a room that is appropriate for providing physical therapy services. Maybe there can be a change in the infrastructure so we can create that space itself. It is also supporting clinicians in many different ways. So it might be with additional education. It might also be with just simple tasks, day-to-day tasks at the clinic, where they might need additional support so they can have the time to focus on the treatment that we want them to implement. So adapt and tailor to the context. And this is really then the more local context. So we might have a great intervention or a great program, a great tool, a great treatment that we have developed. But maybe that works really great in our rather controlled laboratory. But now we need to adapt it to the local context of the clinic. Maybe something that worked really well in our rather controlled area needs to be changed slightly altered without impacting its effectiveness and efficacy, but slightly altered so it will actually work in the clinical setting. We also need to think about providing interactive assistance. So this is really training on the ground. This is by having somebody in the clinical setting and supporting the clinicians by implementing a new way of treating. This can also be done virtually. This can be done in focus groups, in meetings. There's many different ways of doing this, but it's important to continuously assess and support. And then obviously train and educate stakeholders. And this is beyond the healthcare providers or the patients, really training all the stakeholders and informing them about the benefits of the new program or the new treatment. So these are different strategies. They are not the intervention itself, but these are the strategies that we're utilizing to help us implement a treatment or a change in our clinical practice, and to make sure that that implementation is actually successful. Now, I talked a lot about the innovation, the treatment, the program, or the intervention. So that is different from our implementation strategy. So again, the implementation strategy is our vehicle that gets us there, but then the intervention is really the what. What do we have developed as a program, a treatment, and so forth that we do want to implement? So this truly is the evidence-based clinical or preventative intervention, which have been proven to be efficacious and effective. So Hendrix Brown from Chicago, he designed these 7 Ps, which really outline kind of the different interventions that we often focus on implementing. Many people, when they're thinking about intervention, they might just think, oh, it's a treatment or it's a new medication. But there's many other elements that will actually contribute to a person's overall health. So the 7 Ps that he outlines were pills, programs, practice, principles, product, policy, and procedures. So pills is really medications, and focused on medications, so not just pills, but any type of medications. Program can be many different initiatives. Practice is really our clinical practice. Principles, products might be, for example, for our bleeding disorder world, it might be a musculoskeletal ultrasound that we're using. So it's a product there, or it might also be an wearable digital device, things like that. Policy really goes beyond our individual people. It goes into the policies and procedures of the organization, but then also looking larger into federal and state laws and regulations, and then procedures themselves. So these are really then the interventions. But remember, when we're talking about implementation science, these interventions have already been shown that they are working. They have been shown that they are working in a really controlled laboratory setting. They have been shown that they are effective in a more clinical setting. So we are not so much concerned about whether or not these work. We are more concerned about how can we make them work in the real world. And that is implementation science. So in order to set this up and to really investigate and lay the land of what is needed of all of these different options, we're really having to think about our approach. And our approach is designed or outlined really by a program theory. Program theory was first introduced by Volland and Rogers not too long ago, like 10 years ago. Like I said, a young field. But program theory really outlines what is the problem, what needs to happen, and what do we need to do about it. So it's the development of an explicit strategy leading to a chain of intermediate results and final intended outcomes. And it has 2 important parts. So for once, it has the theory of change, which is an understanding of the changes that need to occur to solve that wicked problem. So what do we actually need to do? So we understand the wicked problem. We have identified what we actually need to change in here to solve our problem. And then we have our theory of action. And our theory of action is the construction of a strategy to activate the theory of change. Essentially, what are the different steps that we need to accomplish on the short term, intermediate term, and on long term to really elicit the changes that we desire? And this is truly the development of a logic model. And that logic model will then be our plan of how we are implementing the intervention with what implementation strategies to ultimately benefit the patient. So this is kind of how we are investigating this. Now, what in the world is the connection now? And why are we talking about implementation science? Why is this so important here? And why is this important to our bleeding disorder community? So when we're thinking about bleeding disorders, no matter if we are thinking at VWD, hemophilia A and B, an ultra rare factor deficiency, or platelet disorder, they are complex. They're not very easy disorders to deal with, and they truly require an interdisciplinary treatment approach. One of the prime examples is our pain management, as I kind of threaded through here, but we truly need that interdisciplinary treatment approach. So implementing these are really complex, and that is why we need implementation science there, that we can have a very detailed plan of bringing appropriate treatments advances to the clinical setting. We also have to think about new treatments and programs that are being established to benefit the community, and successful implementation needs to be assured. So we are often thinking here about gene and innovative therapies. So what has to happen on an individual, a contextual, and an external level to assure that these new treatments will actually reach those people that can benefit from them? So it goes beyond of really finding out that these truly work. It is all of the other elements that need to be addressed to make sure that people with bleeding disorders receive the treatments that they deserve. And then lastly, it's really making sure that we are mitigating all of the barriers to accessing appropriate care and treatment. And those need to be identified and then mitigated. One prime example is insurance issues, and in particular right now, our accumulator adjuster issue that needs to be mitigated. But it is really making sure that all the people in our community have access to hemophilia treatment centers, to appropriate healthcare providers, to the treatments that they deserve and need, beyond just the medication. And it's really important that we identify these and that we work together on establishing plans to successfully mitigate these issues so that we can successfully implement the treatments that we know are working. So there's a lot that we need to do, a lot that we need to focus on. And I was very happy to see that in our development of the national research blueprint, that there was a focus on implementation science, because we need to have the support of this rather new science to make sure that all of the wonderful ideas our community has, our researchers have, will actually make their way into clinical practice and improve the care that we deliver. So with this, I just want to leave everybody with kind of final thought. And I know implementation science is a little bit complex and it's a little bit theoretical, so I apologize for that. But I really want to leave everyone with this very final comment that I like so much, which says the use of effective interventions without effective implementation strategies is like a serum without a syringe. The cure is available, but the delivery system is not. So with this, I would like to thank you all for spending your Wednesday with me and listening to something that I feel very passionate about, and that I hope I can spark some interest in some people out there as well in implementation science, because it is necessary for us to improve our health system, our healthcare services, and the care that we deliver to people with bleeding disorders. So with this, thank you so much. I'll be happy to answer any questions. And yeah, thank you for your time.
Awesome. That was great, Lena. Thank you. If you have any questions, please feel free to throw them in the Q&A feature at the bottom of your screen. Right now, I just have 2 questions for you. The first one is, do you know where I can find more information on new treatments and programs that can help our community? Touched on that a little bit at the end, I think.
I touched a little bit on that. So there are many different sources. So one thing is talking to the chapter. So the chapters have resources. Then, of course, we at NHF have a lot of resources as well. And we are more than happy to share. So Handy is a good resource of finding out what is out there, attending our programs such as our Wednesday webinars, but also elements such as our Bleeding Disorders Conference. You learn a lot of new things that are out there at the Bleeding Disorders Conference as well. Just a little shout out, it's happening at the end of August, so there's still time to register and come in. So there is also then obviously the research itself. So if you have access to a university library or so, there's a lot of research available that you can look into. But and then your hemophilia treatment center. So the healthcare providers at your hemophilia treatment center are a phenomenal resource as well. You can always talk to them about new treatments too. So I hope that answered the question. There's many different ways of really finding out what is out there and what is happening.
Great, thank you. So as community members, how do you suggest we participate in implementation science?
As community members, let us hear your voices. So implementation science truly brings many stakeholders together, and it is it needs to hear from the people in the community. It needs to include a bottom-up approach. We need to hear your voices. So there's many different ways of how you can do that. For example, for us in the bleeding disorder community, CVR is a great example. So the community voices of research that NHF has, that is really where you as a community member can provide your voice. Let us hear what you're struggling with. Let us hear where the barriers are. Let us hear where the issues are, because then we can help derive these mitigation plans, and we can formulate the strategies to really overcome those. The other component is, for example, from us, from NHF, we very often send out surveys that really try to hone in on some of the issues. We do needs assessments. So that's where we really want to hear your voice. It's an opportunity for you to let us know what you are experiencing. And then really participating in any of our different focus groups, discussion groups, be involved in any of our task forces. That's really where you can bring your voice to the table. The other element is with your HTC. So have that communication with the members at your HTC and see maybe what projects do they have. Do they maybe have a little bit of an implementation project or something where they are trying to improve their processes or where they are trying to integrate something? Have a conversation with them. Start talking about these elements and how you can benefit. So there's a lot that you can contribute to this. And we want to hear your voice. We want to hear from you. The chapter would also be an opportunity, so you can voice any barriers that you are experiencing in your life there as well.
That was great. Thank you. We have one more for you. Excuse me. So the comment is, excellent presentation. For implementation, resources are key. What do you do in resource poor countries?
Oh, that's an excellent question. Thank you so much to the person who put this out there. So it is not just all about the resources. I think it is in understanding what the underlying issues are. So let's say we are going into an under-resourced country, then we need to really see what are the big issues here that are driving our lack of implementation or our inability to implement this, and then mitigating those. Sometimes it is resources in the sense of money and support. So then we need to find out where we can get that support. But sometimes it's also things like cultural aspects. And we might need to adapt our intervention, our treatment, our program to the local context in that very moment. So there's something that I said in one of the earlier slides, that sometimes we need to do slight adaptations because it doesn't work in the local context. And that very often happens when we're trying to implement something that was developed in a highly resourced country, such as the United States. And now we're trying to implement something similar in a different country that might not have the same resources. One prime example, and this is this is outside of bleeding disorders, but one great example is cervical cancer screens for women, which might be easily done in a highly resourced country like us. And we have issues there too, don't get me wrong, but it's a different story when you're going in an under-resourced country and you don't even have that access to a lot of the tools that you need. So that's where you need to adapt it a little bit and make some changes around it. But at the same time, this also gives you information and arguments of hopefully generating those resources, of finding pipelines of how we can get these resources to the people that we need. WFH has done a great work, especially with the humanitarian aid program, of generating some of the resources and bringing them to the countries. Twinning programs have been tremendously successful too, by twinning a country that has not the same high resources as we do with an HTC or an organization that has really then helped them establish within the local context some of that, and has helped generating those resources. So again, there sometimes needs to be a little bit of an adaptation, but it hopefully also gives an opportunity for generating more resources. I hope that answered the question a little bit.
That was great. Thank you.
Mm-hmm.
All right. Well, let me, I don't think we have any further questions at this point in time. So I want to just thank you one more time, Lena, for taking the time to join us today. We appreciate your time and your very thorough expertise. I'd like to thank all of you for watching and joining us once again. Please note that this recorded webinar will be available on Friday, May 20th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again for joining us and have a wonderful week.